So there are extensive challenges around the genomic testing in the UK environment now. Within lung cancer, we now have 8 oncogenes that we need to test within the test directory, and that lead to potential targeted treatments with either the first or the second line setting. The challenge around that is that we know that our tumour biopsy is often small, our patients are presenting with metastatic disease, and we need those results quickly to get them on appropriate treatment, be it either with a targeted therapy or using standard chemotherapy with or without immunotherapy. The NHS Genomic Services went under, at least in England, underwent extensive reorganisation about 4 or 5 years ago, and I think other areas like Scotland, Wales are also looking at similar things where we're seeing a centralisation of genomic services. So within England and also other parts of the UK, like Scotland and Northern Ireland, are looking at this model. We've moved forward to centralising the genomic testing in what England will call 7 genomic laboratory hubs. And that has led to challenges in that there's now a very complicated potentially pathway where the biopsy is being taken and potentially organised by the chest team. It's going to pathology who are assessing for tumour content. It's then going to a molecular laboratory who do the analysis, and then coming back either to the respiratory physician, the pathologist or the oncologist. And there's lots of potential areas where that process can go wrong and where lots of delays can happen, particularly if you take into account the fact that these biopsies are small and may fail, and you may need to go all the way back to the beginning of the process. In my presentation today, I tried to divide the challenges up into various different categories. You've got the biological ones with the small biopsy, the deteriorating patient. You've got the technical ones. Some of the abnormalities we need to look at are quite complicated. They can't be done by simple one gene testing. Okay, they need next generation sequencing. But then there's a whole raft of organisational ones that have been set up because of the way we've centralised in the laboratory that we need to work around in terms of things like transport, funding, different pots of money for hardware, for staff costs, etc. And then also societal pressures, so the pressure from patients, relatives, other team members to get the patient on treatment quickly. In terms of solutions, I don't think there's going to be one solution that's going to fix the whole system. This is a system-wide problem, and getting the genomic testing right has to be part of the way the team work. It's a team problem, it has to be a team solution. I think there are some relatively simple things that we can look at. So for example, the idea maybe of a tissue coordinator who can track the tissue from the time of the biopsy all the way through that complicated process we talked about to make sure, until the result comes back, and sort of smooth the process and look for any hurdles. We need to be very closely monitoring our turnaround times, not only from the time that the biopsy is taken till the result is received, but look at those individual components that I was talking about to try and identify roadblocks that we can then work at individually. There is a real problem at the moment in how we approve tests. So at the moment in England we use what's called the National Test Directory. So that gives us a list of the tests that the laboratory has to provide. It can provide more, but they have to provide that. And so for lung cancer, it's those sort of 8 genes that we were talking about before. But the problem that we have is that the process of getting a test on the test directory can be quite clunky. They only have one application a year. Somebody has to put the application in, which is often an oncologist. And then even when it's approved by the committee who look at it, it has to be signed off by NHS England. And that doesn't always marry up to drug availability. So we have run into the very challenging solutions in the past where we've had access to a drug, but we haven't been able to identify the patients. So we need to, that process needs to be reformed. It's a key priority to me to try to bring the approval of tests up to a similar speed and standard as to how we're now approving the drugs. So one of the potential solutions that people are interested in is a suggestion that we might use a circulating tumor blood sample for rapid diagnostic testing. And that's got certain key advantages. It can be taken at the time of clinical appointment. It goes away, you can get your next generation sequencing. It takes away some of that process that we were talking about earlier about going to a molecular laboratory and then onto testing. So it's been very elegant work presented by Professor Popat at Marsden, who showed that if you take that blood sample when the patient first sees the oncologist, you can dramatically reduce the time when you get to where you get your molecular results back. But most importantly, he showed that you can cut down the time to getting the patient on treatment by about half. So what we're now doing to take that forward with NHS England is we're running a pilot nationally through the GLH and the Genomic Medicine Service structure, where we're looking at what about doing it when the patient first presents to the respiratory physician, when they've got a CT scan showing metastatic lung cancer. Can we take the sample and get that diagnostic information back even earlier, potentially even before the patient's at the MDT? And does that speed patient care, and is that a cost-effective use of NHS resources? As part of this, a very important change was that previously the Cancer Drugs Fund or NHS England commissioning, we have to fill in what's called a blue tech form that says that the patient meets certain criteria before we're allowed to prescribe the drug. And that always used to say a histological diagnosis of cancer. But we know these tests are these circulating tumor tests. There's no issue about the technical validity. If they find something, it will be a genuine result. Many of these, the two big companies are FDA approved as companion diagnostics. And so we were able to work with NHS England to change those criteria. So now any access to targeted therapy in lung cancer will say histological diagnosis of cancer or a ctDNA finding in conjunction with a radiological diagnosis of metastatic lung cancer. And to me, that's been a major improvement.